Welcome to this OncLive News Network presentation, broadcasting live from MJH Studios. Today's discussion will be focused on systemic therapy for hereditary breast cancer and evolving treatment strategies in this setting. I'm your host, Dr. Joyce O'Shaughnessy. I'm the Celebrating Women's Chair of Breast Cancer Research at the Baylor University Medical Center, Texas Oncology, and U.S. Oncology in Dallas, Texas. And today I'm joined by two colleagues who are experts in breast cancer treatment and research. Dr. Tnt Trial, Clinical Director of the Breast Medicine Service, Associate Attending Professor, and Section Head of the Triple-Negative Breast Cancer Research Program at Memorial Sloan Kettering Cancer Center, and Associate Professor of Medicine at the Weill Cornell College of Medicine in New York, New York. And Nadine Tung, Associate Professor in the Department of Medicine at Harvard Medical School, Director of both the Breast Medical Oncology Service and of the Cancer Risk and Prevention Program at Beth Israel Deaconess Medical Center in Boston, Massachusetts. And during the next 60 minutes, we're going to navigate through some of the questions surrounding how we treat patients with breast cancer and germline mutations in BRCA1 or 2. And we're going to consider how the availability of PARP inhibitors will change the treatment landscape going forward. During the last few minutes of this broadcast, we'll answer questions from our viewing audience on the topic of BRCA-mutated breast cancer. During the broadcast, we invite you to submit questions to our panel by using the entry field located below this video. So with that, we're going to start by talking about Braca testing. You know, we've been working hard over the years to remember to try to do germline testing in women who are newly diagnosed with breast cancer, but it hasn't really been so much of an emphasis in the metastatic setting. And now here we are, because of the availability of olaparib and soon to come other PARP inhibitors, that's in the metastatic setting. So who are we supposed to be treating in the who is supposed to be testing in the metastatic setting for germline BRCA, Nadine?
Exactly. Well, there's a new test to treat criteria put out by NCCN, which states that if a woman has metastatic HER2-negative breast cancer and would be appropriate for treatment with specifically olaparib, because that's now FDA approved, that germline BRCA testing is appropriate for that patient. It's not entirely clear how many additional BRCA mutations we're going to find compared to the previous NCCN criteria, because that was extremely sensitive for finding BRCA carriers in newly diagnosed or the early setting. But nevertheless, it does allow us to be more permissive in our genetic testing. I don't know that a triple-negative breast cancer patient has to be limited to diagnose age 60 or younger, for example. And I think then one of the questions that really comes up is, do we test women in the initial setting? Do we test them in the metastatic setting? Do we do germline testing? Do we do somatic testing? And I think just a few sort of take-home messages are probably good to remember. I would say that still in the early setting, when a patient is appropriate for germline BRCA testing, they should be tested. It has implications for their surgery, et cetera, and perhaps prophylactic oophorectomy, et cetera. But in the metastatic setting, it can get a little tricky. We're doing a lot of somatic testing to guide our treatment. So I think that some of the principles I would say is that if a somatic BRCA mutation is identified, those patients should be reflexed to germline testing. Most, but not all, of the patients will have a germline BRCA mutation. About 4% will just have a somatic mutation in breast cancer. So positive reflexes to germline. I would say no matter what the somatic tumor testing shows, if that patient meets traditional NCCN criteria for germline testing, do the germline BRCA testing. Sometimes the tumor won't show it, but the patient has the germline mutation. You don't want to miss it. And then the last thing I would say is the VUS. We've really educated our clinicians that a variant of unknown significance should not be treated like a BRCA mutation. And in the germline setting, we don't act on VUS. In the somatic testing, I think it's still evolving. If I were to get a BRCA1 or 2 VUS in my somatic testing, I would check the databases like ClinVar for the germline testing, and if I could prove it was a benign change or a VUS, I would ignore it. But otherwise, I would reflex to germline testing because I don't think the somatic databases are as established or well worked out. This would be my point.
No, thank you. That is terrific, and it's terrific that NCCN now has said that anyone who might be a candidate for olaparib or in the future other PARP inhibitors with HER2 negative disease is eligible for testing. So that really gives us a lot of leeway to do so for these patients, if we can remember to do it, in the metastatic setting, which is sometimes challenging with everything else going on with those patients. So do you think, Tiffany, that we now have a new subset of breast cancer? Is this like a new type of breast cancer, the germline BRCA? We need to be looking at it differently, prognostic-wise, treatment-wise?
Great question. So I think we've all been grappling with and recognizing the heterogeneity of breast cancer and even triple-negative breast cancer. And we've had groups look at molecular characteristics and classifications for TNBC. I think we've all suspected there was a subset of triple-negative breast cancer in particular that behaved differently. In the Pete and Pohl subset, these were the more basal-like, highly proliferative tumors. And I would say yes, we now can carve out patients that have a germline BRCA mutation as now an actionable biomarker. So while it certainly has implications in the early stage setting for risk-reducing interventions, it is now an actionable subset of breast cancer. And so in my paradigm now of approaching a woman who has a diagnosis of breast cancer, as I'm trying to think about a treatment plan, I feel that I need to know the germline BRCA status to make those appropriate decisions. In terms of prognosis, I think the data, largely from retrospective series, has been somewhat mixed. And I think at best we can conclude that the prognosis is really comparable, whether you have a germline BRCA mutation or not, once you have adjusted for other known prognostic factors.
Yeah. Do you agree?
I would absolutely agree with that. Absolutely.
And you think of BRCA as a new kind of fourth subtype, if you will. Well, maybe we've got four. We got luminal A, we have luminal B. Those are very, very different biologies, Do you think we got a new subtype of breast cancer here?
I think absolutely, and I think it's important to really focus your thinking that way so that you don't forget to do the germline or the somatic testing, both for treatment, as we're going to talk about standard treatment, but also for trials and PARP inhibitors. So I think if we can think about the different subsets with BRCA as a separate, it will help us.
Because even regardless of any family history whatsoever, what's the chances we're going to find a BRCA mutation in somebody with Zippo family history? Here they are in the metastatic setting, triple negative ER positive. What's the chances we're going to find it?
Yeah, well, I think there's some difference in data. I think what we've learned, for example, in the Ashkenazi Jewish population is that half of the mutations we're finding in the general population are patients that don't necessarily have a personal or family history. But if we're thinking in breast cancer, clearly there are some groups that are enriched for this. Triple negative breast cancer, younger age, again, Ashkenazi Jewish. So I think if somebody has an extremely large family and no family history, certainly the chances are much lower. But I would say again, in the metastatic setting, if you're doing somatic testing, you may pick them up. But otherwise, I think if you would use the PARP inhibitor, it's worth thinking about the germline testing.
Because I've seen estimates up to 11, 14% for TNBC. Yeah. Yikes. So, that's pretty high. And I've seen estimates as low as 5%, though, too. I guess
I think it's between 10 to 20% for triple negative. I really do. I think unselected all breast cancer, we're talking 3 to 5%. But for triple negative, it's between 10 to 20%.
Yeah. So it is something, and we don't want to miss it because we're just at the tip of the iceberg. We're just starting down the road of how to optimize the treatment for these patients. I guess another question is we do find these variants still in the germline, less and less with the BRCA1, 2, maybe more and more with some of the other germline, which we'll come back to. But would I be wrong if I had a patient who's got a strong family history that's kind of suggestive of a germline mutation, but she just has a variant that truly is unknown at this time, and now she's got metastatic disease. So she's kind of acting. Let's even make her triple negative. You know, would be wrong to give her the benefit of the doubt and treat her with olaparib? What do you think, Tiffany?
Well, a patient like that would not have been included in the 2 big randomized phase 3 trials that have reported out data. So I don't know that we have evidence to support that there would be a benefit for that particular patient. I could sense why it's so compelling to think about an attempt there, but I guess I would say, since there are several recruiting trials for PARP inhibitors in metastatic disease, I would favor that approach first so that we could try to learn something from the experience.
I agree completely. I think we don't want to get away from the message that VUS really, most of them, 85% of them, are not going to be pathogenic mutations at least. So I think we shouldn't be treating them like mutations.
Cool. Well, thank you. Now let's go on to the topic of the most recent FDA approval of olaparib in the BRCA mutant metastatic patients. So I guess it comes into the context of how we've been treating these women anyway. You know, we've been treating them, and you know, we've known that they have BRCA mutations, that we're in the metastatic setting, let's say. What kind of approaches have you've been using, you know, Nadine, and we'll get also to the preoperative, which is a bit of a conundrum, you know, with regard to the BRCAs. But in the metastatic setting, what kind of data do we have, you know, with regard to chemotherapy?
Okay, so for chemotherapy, I think what Tiffany was alluding to is we do get some sense about different responses to chemotherapy, and I think the Tnt trial is probably the one to start with and to talk about. So the Tnt trial, if people remember, was a randomized phase 3 trial for patients with triple-negative breast cancer, but also for those with a germline BRCA mutation. So in that study, there were 43 BRCA carriers. Most of them had triple-negative, 31 of them. There were a few ER positive, but 43 BRCA carriers. And the study was a randomization in the first-line metastatic setting to either platinum or to docetaxel, carboplatin. And at progression, there was a crossover, and there was always a pre-planned analysis by BRCA status. So the take-home message in that study was that overall, there was no advantage. There was no difference in response rate or progression-free survival between the platinum or the docetaxel, except for the germline BRCA carriers. They had a significantly better response rate and a bit of a better progression-free survival. So this confirmed older, smaller studies that showed that platinum seemed to be more active among the triple negatives in those who had a germline BRCA mutation, and that it was better than docetaxel and better than those who didn't have a BRCA mutation. So platinum's an active agent. There's no doubt about that. I think the question then becomes, is platinum better than standard chemotherapy? Is it better than anthracycline-based regimens? And I think we don't have a direct comparison to answer that question. I think the only other data to me that speaks to it in some prospective way are studies like GEPAR-6do. So this was a study in the neoadjuvant setting for triple negative using a little bit of a different regimen, but a weekly anthracycline, a weekly taxane, asking how much benefit did you get if you add the platinum? Do you get a better path-CR, better disease-free survival? And interestingly, if you look using the standard therapy, you look at the BRCA carriers, there were 50 of them, versus those without the mutation, the path-CR rate was much higher in those with BRCA mutation standard therapy, 68 versus 33% path-CR. So standard therapy is very sensitive in the BRCA carriers. If you asked, did the platinum add anything, it only added for those wild type, those without the BRCA mutation. So one interpretation of all of this is that BRCA-associated breast cancer is more chemosensitive. Platinum is active, standard therapy is active. Until you compare them head to head, you don't really know which is better. And we're actually conducting a study like that in the neoadjuvant setting, just comparing cisplatin to AC. And I think that will provide some data even in the ER-positive BRCA-associated breast cancers for which there's no platinum data at all. So I think chemosensitive tumors is what I would say at this point.
And that's really interesting. We don't have a whole ton of data in the metastatic setting with regard to chemotherapy, but the TNT with carbo was really a nice level 1 evidence, albeit a small subset. But that really is interesting about the Gephardt-60. No additional benefit from the addition of the carbo in PAF-CR or disease-free survival in that population. How about in the metastatic setting with the BRCA patients, kind of heretofore, before olaparib came along, for example, did you kind of prefer to start with a platinum or not necessarily, or?
I think that it's been somewhat evolving. These patients often in the early stage setting would have received an anthracycline, a taxane. They may have received a platinum. In the time of CREATE-X, they may also have received post-neoadjuvant therapy with capecitabine if they failed to have a PAF-CR. So a lot of this is the art of medicine. It depends on what they've previously seen, how long of a disease-free interval did that patient have. But I think that taxanes, platinums remained really a first-line option. And personally, I found I was moving eribulin up sooner in the metastatic disease course for these patients as well.
Mm-hmm. So let's talk a little bit about, before we get to the new olaparib data, just the interest in the controversy, the struggle we all have in the day-to-day practice about, you've got a germline BRCA patient, but she's in the curative setting. And let's just make her in the preoperative setting. And she could either, of course, be triple negative, or she could be ER positive. Do you treat her any differently today, based on what we know today, with regard to how you'd give her preoperative therapy? How about you, Tiffany? What are you doing in your practice?
Well, I would say this is a perfect opportunity on the heels of Olympiad to pursue accrual to Olympia, which is an adjuvant study for olaparib in patients with germline BRCA mutations, to see if there's potential benefit to the addition of olaparib following standard of care adjuvant therapy.
Yeah.
I think that the neoadjuvant approach is a really compelling one because we can enrich for response to therapy and know who may potentially need additional treatment after surgery. We know that we can downstage the axilla, so with pre-op therapy, we're allowing our patients to have less morbidity from their surgery choice. So I think that the neoadjuvant setting is really a rich one. I don't know that it necessarily changes the backbone regimen of chemotherapy that I'm offering, though.
Do you use much in the way of platinum sort of up front, or do you wait to see what the the pathologic response is before considering an adjuvant platinum in the BRCAs, in particular?
In the germline. So,
yeah, the germlines,
as you've heard, in the germline setting, it's unclear if platinum has really added anything. So these are also women that often are having risk-reducing mastectomy at the time of surgery. So it's not clear I'm allowing them to have breast conservation as a result of adding in the platinum. I would certainly consider it for the opportunity to downstage the axilla, but it's really a multidisciplinary discussion about whether the platinum is necessary or not.
And how much you really have to get cytoreduction of that before their surgery and such.
Correct.
How about you, Nadine? What are you doing nowadays with the BRCA 1 and 2 germline BRCA patients, early stage disease?
Well, I would say that really the same thing. I'm not really changing the chemotherapy I give. It's nice to know that platinum's an active agent. And again, most of our data is in the triple negative and in the BRCA 1. So certainly, if I'm concerned about anthracycline or somebody has a contraindication, I'm very comfortable using a platinum-based regimen, and that's nice to know. And I think otherwise, as I would probably, despite what I just said for Gephardt-60, if I'm starting with my AC in a triple negative and I'm not getting the response I want, or there's still significant disease, I'm probably going to add the carbo the way I do it weekly with the taxane and think about that. But you often get very, very good responses with standard therapy.
Mm-hmm. So you'll flex it. You'll flex it, kind of, guided by the response to AC. And if they just have a clinical CR real fast, you won't necessarily, because Gephardt-60 is quite interesting. Hopefully the CLGB 40601 trial that also looked at the plus minus platinum will be able to look at a BRCA cohort, and hopefully we'll tell the same story. So we'll have some clear guidance there. I do the same thing. Somebody comes in with just a huge amount of disease, big, nose, very going to be difficult operation. I will kind of tend to add it, I'll start with AC, then go on to paclitaxel, carbo, or if they do real well with standard therapy and they aren't a PAF-CR, and they have a germline BRCA, I will give the capecitabine, per the CREATE-X afterwards, but I have found good safety adding 4 cycles of carboplatin, just AUC of 5 or 6 every 3 weeks with the carbo, no problems at all, and then finishing up the 6 months of the capecitabine. So I kind of flex it too. So I'm still sort of adding it on in the highest risk population just because we don't know yet, and we have the NSABP randomized trial going on in the, but that's not germline BRCA patients, but at least we're going to find out what platinum really does overall, but we just really don't have super great data yet in the disease-free survival, particularly in the BRCA population.
I would say you said about CALGB, we're waiting for that, the 40603, right?
40603, right.
The I Spy the Brightness study, which was just published, was sort of similar. They used the taxane versus AC, weekly Taxol, and they added either carbo or carboviliprid, which we'll talk about the PARP inhibitors later. But if you look at that paper, I would say again, I think they had 93 BRCA carriers. It's sort of a similar story. The benefit didn't look quite as large with the addition of the carbo, sort of none with the viliparib, as it did in the non-BRCA carriers. Again, these were triple-negative breast cancer. So I think there's a few lines of evidence that perhaps they're so chemosensitive that the standard therapy is good.
Yeah, interesting. So there's a couple. There are a couple that's interesting. It kind of not what we expected.
Yes.
Not what we thought the platinum was going to hit it out of the park, for the BRCAs, but they do so well in general with chemotherapy that what's the additional, maybe platinum's just not that non-cross resistant to an AC type regimen.
Now again, a different argument might be if it's better when a direct comparison or less toxic or whatever. I think there's a different argument to be made for substituting, but we don't have that data yet.
So let's go on to the new data that we need to incorporate into practice. Tiffany, the Olympiad data. Could you tell us about that?
Happy to. I think this is exciting data. So Olympiad was a randomized phase 3 trial of almost about 300 women who were germline BRCA mutation carriers, and this was on central testing. They were women who had less than 2 prior lines of chemotherapy. And I think a really key point here, as we've been talking about platinums, is that a portion of these women had prior exposure to a platinum, but you could not have progressed on platinum-based chemotherapy. So these women were randomized to either single-agent olaparib or treatment of physician's choice, which was a reasonable list of standard drugs that we use for metastatic breast cancer, excluding a platinum, right? So there was no platinum-based therapy in that control arm. And so the primary endpoint was median progression-free survival. And the trial robustly met its primary endpoint. So PFS improved from about 4 months to 7 months, and that was about a 42 or 48% improvement in progression-free survival. Other efficacy endpoints, there was a doubling of response rate from 30 to about 60%, favoring olaparib. And this is, again, a single-agent oral therapy for patients. In terms of toxicity, olaparib as a single agent was really relatively well tolerated. There was some hematologic toxicity of a bit of anemia, which I think was no surprise to folks from the phase 2 experiences, and a bit of nausea and vomiting. Although when you looked at how that compared to treatment of physician's choice chemotherapy, in fact, the discontinuation from therapy due to adverse events was lower with olaparib than it was with standard chemotherapy, and it was rather uncommon. The study actually looked at quality of life endpoints as well. And I think something that was very reassuring was that the time to a deterioration in quality of life was prolonged with olaparib over chemotherapy. So I think we had encouraging efficacy data. The study met its primary endpoint, as well as a nice tolerability profile and improvement in quality of life, really what it meant to our patients.
And so that it made itself right into the New England Journal of Medicine and then right to the FDA approval. So what do you think the impact is on our standard practice? Is this going to be a kind of a game changer for the germline BRCA patients, do you think? Or
I do. I think there are a few things that I took away from these data. Number one is how critically important it is to know a patient's germline BRCA status. So we've talked about NCCN guidelines already, and this is really a reminder to make sure we're not missing patients that could have the opportunity to have access to this treatment. I think that we then divide out by biology what we're doing in the triple negative setting and what we're doing in the ER positive setting. These patients were HER2 normal, so that's a separate category altogether. I think it's a wonderful opportunity for patients with germline BRCA mutations and triple negative breast cancer to see that we had improved progression-free survival with an agent that was so well tolerated, that was oral, that did not have alopecia associated with it, is really a win. And I think it moves up to first-line opportunity for patients. In the ER positive setting, again, compared to chemotherapy, this was superior. So I still think this would be sequenced at some point following endocrine therapy. I'd be happy to offer olaparib to my patients over chemotherapy. Right? We all know when clinically we're making that transition from an endocrine approach to a chemo approach, and I see olaparib moving in earlier for our patients with germline mutations.
Now there was a companion diagnostic, right? It was a complement to the approval, right, of olaparib. But truthfully, we can use any of the germline. Is that
I think we do. I think we're using by any CLIA-approved lab. I think BRCA germline mutation would qualify for use of olaparib.
So we have to have the germline BRCA, but any CLIA-approved, that's fine.
I think so.
Just an aside question is, if we're going to get the germline BRCA testing, should we do panel testing for our metastatic patients? Is it more costly to do that, or we would anticipate it probably be covered since we're kind of getting that pretty much, I think, across the board in the early stage setting? What do you think? What do you do?
Well, I think that for the early stage or for germline testing, for most patients, it's not very common to just be getting BRCA1 or 2 anymore. Honestly, there are other high-risk breast cancer susceptibility genes. There are moderate-risk ones like ATM and CHEK2, and there aren't any predictors or indications specifically for testing for those more moderate-risk ones. So I think a lot of breast cancer patients are getting the panels for breast cancer susceptibility genes, perhaps for ovarian cancer susceptibility genes, because there are some new genes for which mutation carriers should probably be having a discussion about prophylactic oophorectomy. So I think a lot of these genes that are breast and ovarian cancer susceptibility genes are DNA repair genes, just like BRCA1 and 2. They function in the same pathway. Whether the patients with germline or somatic mutations in those other genes will respond to any of these therapies or anything we're talking about is relevant to them, we don't know yet. But in terms of risk prediction and risk management, I think a lot of patients are getting multi-gene panels with cancer susceptibility genes to other cancers.
And that might help them with regard to enrollment in clinical trials. If they're in the metastatic setting, get the panel, they come up with an ATM, there's a trial for them, right? So that's pretty good.
Absolutely.
Yep. So how about you, Nadine, how is the availability of olaparib now changing your practice for the triple negative and the ER positive patients?
Yeah. I think that I agree with Tiffany completely. I think for triple negative, I mean, it would be, if I were going to reach for a single chemotherapy agent, I would reach for olaparib. I think if I needed a doublet and somebody was very sick, that's a different story in the triple negative. I think we don't have a direct comparison to platinum, and I think if you do what you're not supposed to and look at a cross-study comparison of the Tnt trial and the Olympiad trial, boy, the progression-free survival looks pretty the same, response rate in the first-line setting looks pretty the same, but I think the toxicity would be so much less. So to me at this point, single agent, triple negative, I would reach for olaparib, as Tiffany said. The ER positive is interesting because in the Olympiad trial, those were endocrine-resistant patients. They had pretty much all seen endocrine therapy in the metastatic setting. So they're more like patients in Paloma-3 or Monarch-2. Almost none of them had seen a CDK4/6 inhibitor. So I agree. I guess if you're a purist, you would keep with your endocrine therapy as long as you felt that the patient was appropriate for that, you were getting response to endocrine therapy, and then when you're going to move to chemo, use olaparib. Although I must say, I think to myself, I think of the toxicity with these two oral agents, and I think one could make an argument, if I had an ER-positive patient with a germline BRCA mutation who'd progressed on an AI, would I use a PARP inhibitor? Would I use a CDK4/6 inhibitor? There's no direct comparison or data to really draw upon for that.
But that's interesting. So you both would really favor in the triple negative somebody who wasn't very, very ill, going right to olaparib, for the first line treatment for that patient. I would too. I haven't had the opportunity to do it yet, but it hasn't come up yet. But I would do the same. I would do the same thing.
And can I have one more comment? In the Olympiad trial, and again, it wasn't platinum, but compared to eribulin, compared to capecitabine, the time to response was the same. It was about 45, 47 days. And that's important because we think, a pill, we think endocrine therapy, this is going to take a long time to respond. It was the same. So we need to get over that psychological barrier that it's going to take longer or something.
Yeah. Is a little analogous to the CDK4/6 inhibitor issue in the first line metastatic, but it's not for the germline BRCA, for the wild types. It's very effective therapy, but if you have somebody that you heretofore would have given chemotherapy, are we comfortable using a pill instead? And again, the time to response is very, very quick, but it takes a little time to evolve those patterns, doesn't it? You know what I mean? So I think we're going to be probably getting there more and more. So that's really very interesting, and the hope is that the median PFS, when we move it up, will be, much longer. That's the hope, that we can see. And then in the ER-positive patient, where there's so many other options, and we do that first line CDK4/6 with 24 months median PFS. That's pretty much a stand up and salute.
But again, those are endocrine sensitive.
Those are endocrine sensitive patients. And it's really a mixture where the luminal A's outnumber the luminal B's, probably disproportionately, but the BRCA2s, would maybe be considered perhaps a little bit more aggressive, because most of the BRCA2s with the ER-positive, probably fair to say, are more like a luminal B biology.
Interesting. I think the ER-positives in all the BRCA carriers tend to be the luminal Bs more so. They higher oncotype recurrence score, a higher proliferative rate, so they tend to be luminal B. They do.
Yeah. And, all we've seen in the CDK4/6 studies has been the forest plots where everybody benefits a great deal more. But I don't know that I could quote you, from looking at, PAM50, luminal Bs, what the PFS versus the luminal A's. Probably a lot of that is still ongoing, a lot of that. But
just thinking about where to sequence this, say we leave first line off to the side, and that's where a CDK4/6 inhibitor is. We've all had women with ER-positive disease struggle with the bone-related adverse events from aromatase inhibitors, or some of the mucositis from, say, mTOR inhibitors. When you look at the toxicity profiles, actually olaparib in that setting would be pretty well tolerated and very reasonable, I would think, to use for someone, even with ER-positive disease in the second-line setting, who's having a hard time with endocrine therapy.
And we all gauge it, right? How many lines of endocrine therapy we give depends on what's going on with the patient. How well did they do with the previous endocrine therapy? So everybody's going to be different in terms of how many lines of endocrine therapy. But it sounds like we're all on the same page, that before we would go on to our next, oral capecitabine, for example, where that might have been what we would do next, we'd go on to olaparib. Yeah. So that's really interesting. We're really moving it up. So that's really going to be interesting to see how that goes to the patients. We really hope we get those wonderful durable responses. We're just taking a pill. So let's talk about what's coming soon. We're going to be looking at probably a second PARP inhibitor that's going to be approved, we hope, fairly soon, and that was based on the Braca data, which just came out, in San Antonio, it just came out. Could you tell us about that?
Sure. So Braca used talazoparib, a different PARP inhibitor, but otherwise was a very, very similar randomized phase 3 trial. Really the same population that Tiffany just talked about in Olympiad. These are patients with metastatic breast cancer, HER2 negative, germline BRCA mutation, no more than 2 chemotherapy in the metastatic setting. And again, they were randomized to either single agent monotherapy PARP inhibitor, this time talazoparib, or to again, standard chemotherapy, not platinum. So really almost identical design. And the efficacy, the results were very, very similar. Again, there was a significant improvement in progression-free survival. Median PFS was improved by about 3 months. Again, the hazard ratio, 0.54. So really so similar. Still like Olympiad, no improvement in overall survival, although I think there's hope that the curves will separate. The hazard ratio was 0.76, which was tantalizing, so we'll see. But very, very similar efficacy. Again, better quality of life than the standard chemotherapy, so very similar. Toxicity was different. I don't know if you want to hold off on talking about that, but a little bit different. A little bit of alopecia, 25% had alopecia. That may be significant, and a bit more myelosuppression. So I think the toxicity was a little bit different. The efficacy really looked similar. There are other PARP inhibitors, but Braca is really the most far along in terms of the phase 3 that we heard about in San Antonio. So I think that that's the next one. There are other PARP inhibitors being evaluated in the early setting, which I think we may talk about later. Olaparib in the adjuvant setting, and some other ones moving all the way up into the neoadjuvant setting. But I think that's the other well-established, and I would be, looking for FDA approval in that one.
What can we learn? What have we learned so far about the utility of PARP inhibitors in someone who's had a platinum agent? I think this is going to come up, for our patients, particularly in the metastatic setting, triple negative, before Olaparib was available to them, or soon to be, we hope, talazoparib, women got some platinum. And so what do we know from Braca or Olympiad in terms of timing? If you were to do one, immediately upon progression on a platinum, would you get anything? Should we try to separate it out? Is there a differential benefit between those who have had a prior platinum and those who hadn't had a prior platinum? Didn't the Braca look at that a little bit?
Yes. Well, first of all, Tiffany, it's important to say that both of those phase 3 trials in Braca and Olympiad excluded patients who had platinum refractory. You couldn't have progressed on a platinum. You could have had it in the adjuvant, but you can't. It had to be a good 12 months before you develop metastatic disease, or you couldn't be refractory. Your point is excellent. I think that platinum sensitivity, there is data that it predicts for response to a PARP inhibitor. More data even in the ovarian cancer population, I think, with platinum refractory disease, almost no response, and platinum sensitive, where you're recurring more than 6 months from your last platinum, high response rates.
6 months in the ovarian.
That's in ovarian. That's how they define platinum sensitive. Platinum refractory is your tumor is growing while you're being exposed to platinum, with platinum resistant in the middle between. That's how the ovarians define it. In breast cancer, we have much less data, but one clue was the phase 2 trial with talazoparib. I think the Abrazo or Abrazo, I never know if I'm saying that correctly. But they had a cohort of patients who had seen prior platinum. And they're small numbers, but there were 7 patients in that cohort who had a platinum-free interval of less than 8 weeks. I interpret that as their platinum refractory. None of them responded to the talazoparib, whereas those that had been more than 6 months from their platinum, their response rate was like 47%. So I think this theme that if you're platinum refractory, your response is going to be very low, and if you're platinum sensitive, higher chance, it would carry over.
Interesting. Right. And Braca had 2 separate cohorts, right? One was allowed to have had prior platinum.
That's a Braca. That's
Abrazo. That's a phase 2. And Braca, the phase 3, was just like Olympiad. You could have had prior platinum, you just couldn't be platinum refractory.
Okay, yes.
Right.
They stratified.
They did stratify
in
for it.
Olympiad.
Right, so in Olympiad, about 30% of the patients had seen prior platinum. In Braca, I can visualize that forest plot. Really, regardless of prior exposure to platinum or not, it benefited the PARP inhibitor over treatment of physician's choice.
But these were not platinum refractory.
Correct.
Right, gotcha. That's interesting. So it may end up being similar to the platinum story. We need more data, but from a practical standpoint, in your practice, if someone's had platinum, but they're a germline BRCA1, and you'd like to give them the opportunity for Olaparib they had benefited, in the past,
right.
you'd consider coming
Sure, I mean,
back.
I think that scenario is very likely that you would have seen an amazing response if you used a platinum in the neoadjuvant setting, for example, and you saw the tumor melt away clinically, and maybe they even had a path CR, and yet later they present with metastatic breast cancer in that germline setting. That person would be a candidate for a PARP inhibitor, and I'd be enthused about it.
I agree.
You do, and even metastatic platinum, of course, in the Olympiad you were eligible, and in BRCA, as long as you hadn't progressed.
Correct.
But sometimes we do keep going the platinums until they do progress. They do progress, right? But then maybe they do well, they've done well, and then later on you can come back. Maybe you wouldn't necessarily rule that out down the road for someone.
I think the patient would be the one who got platinum but stopped because of toxicity, got a response, and then you went on to something else. Or I think that's the patient you might.
Because that's where the data really speak to not becoming refractory to it. So it sounds like the efficacy data was very similar between the talazoparib and the olaparib. They were very, very similar in that sort of later line population, but some differential toxicity, not wildly dramatic, but so they may not be like totally interchangeable. It sounds like, huh?
Right. I think that it's really a bit of the toxicity differentiator. You already mentioned the alopecia standpoint, where I think it was incredibly uncommon, maybe 2% or so in Olympiad versus 25% in Braca. And alopecia is meaningful if we're trying to get away from significant toxicity for our patients. A bit more in terms of hematologic toxicity seen in Braca with a PARP inhibitor versus olaparib on Olympiad. I think they called out in Braca a subset of patients that had prior stable CNS metastases. And it appeared that they derived benefit. I don't think that tells us that olaparib wouldn't have benefit in that situation, but we just don't see any differential response in the setting of CNS disease.
No, I agree. I think there's been a lot made about the different PARP inhibitors and their mechanism of action and trapping PARP proteins and being more potent or less potent, and we see tables about which ones are more potent, but I think in these two, it looks like the efficacy thus far is pretty similar, so I don't know if any of that potency or mechanism of action is going to translate to clinical differences or toxicity differences.
We don't know yet.
We don't know.
That's the trapping of the PARP enzyme, so it doesn't fall off, and you really just don't complete that repair of double-strand breaks. So we just don't know yet. That's a potency issue, but we don't know yet clinically. But so there was more anemia.
Yes.
And neutropenia and thrombocytopenia. Is that right? With the,
absolutely. I think if you look at how much grade 3 or higher anemia there was, olaparib there was 16% in Olympiad, and there's like 40% with the Braca study with the talazoparib. If you look at thrombocytopenia, grade 3 or higher, you're talking about 2% versus 15%. So there are differences. I mean, I think there's no doubt when you look at the studies, one thinks about, well, is one of these more potent or has more toxicity, but again, does that translate into efficacy? Will it translate into survival? I think time will tell, but at this point, I think efficacy looks similar.
And there was maybe a difference in BRCA 1 and 2 between the studies. I think, wasn't there a little suggestion with talazoparib that maybe it looked quite good in the BRCA 2, and then in the Olympiad, maybe that wasn't quite as prominent or something. I remember some
Olympiad is a 60-40 split, so 60% BRCA1, 40% BRCA2. And 50-50 on ER positive and triple negative.
And again, I think when you look at these forest plots, at this point, I can't find a subgroup of patients who met the eligibility criteria that I wouldn't use either olaparib or.
Because we're getting into subset analyses.
Which were not planned,
and
they're
the confidence intervals
exploratory.
are fully overlapping, and so, but that is something that I remember having a question on, but it's just, these are subset analysis, and it's like everything, like the CDK4/6, every single subset benefits,
Exactly.
And so, we hear a lot about homologous recombination deficiency and hoping to be able to find other patients that may be not a germline BRCA that we may eventually be able to offer PARP inhibitors to. Where do we stand right now on trying to identify these these patients by some sort of other surrogate endpoint, surrogate diagnostics besides the BRCA testing?
Well, I think that's the goal. Find the breast cancers and the non-germline BRCA carriers that are going to respond to PARP inhibitors and other DNA damage agents. So I think they're being developed. I would start by saying they're not in clinical use yet. I would categorize them. I would say one group looks at genomic loss. And I would say that's like the Myriad HRD assay that many of us have read about or heard about. That was tested in the Tnt trial to see if you could identify those breast cancers that would also benefit more from platinum than docetaxel, and it was not successful. I do think there was a criticism that they used the primary breast cancers and not a biopsy in the metastatic setting, but that didn't pan out. On the other hand, in the neoadjuvant setting, there are some reports that a higher HRD score will predict for response to platinum or response to other chemo, so there may be something there. A whole nother approach, rather than genomic loss, is looking at these mutational signatures. So the concept there is, in a BRCA-associated breast cancer, there are signatures, there are combinations or patterns of mutations in the tumor, and there are several that are characteristic of those tumors. So can you look in other breast cancers, look for those mutational signatures, and that will predict for similar response to treatment. So we have assays like, or tools like HR Detect, which uses whole genome sequencing, and again, looks very sensitive in the reports to be able to identify patients with germline or somatic BRCA mutations or silencing of the BRCA genes. But again, I think we need to wait and see if these are going to pan out in the clinic.
So a lot going on, a lot of interest in this whole, what is the mechanism of DNA repair in these other cancers, and can we exploit that, but nothing for us today in the clinic, nothing yet for us. Right. So Tiffany, where are we going with the PARP inhibitor? We got the single agent, it's a good start.
Sure.
But what can we add to these things, you know, to help make the next advance? What's the most exciting research going on?
So I think there's a trial that reported out recently, you know, in oncology, often when we find one drug that works, we try to combine rational combinations and hope that it'll work even better for our patients. So immuno-oncology has been such a hot field, and checkpoint inhibitors have been exciting. So there was a recent presentation, Susan Domchek presented the Mediola study, which looks at partnering olaparib with an anti-PD-L1 inhibitor. And there, this is a single-arm study, a lead-in of the single-agent PARP inhibitor, and then adding in the anti-PD-L1 antibody. And there, the primary endpoint was a disease control rate in a very short window of about 12 weeks. And the study had about an 80% disease control rate at 12 weeks, which is close to essentially what they were aiming for. But when you look at something like an objective response rate, it was quite comparable, say, to the olaparib arm of Olympiad. So I'm not quite sure in that setting how much adding in an IO agent added to single agent olaparib. But it does raise the idea of that paradigm, perhaps, as a maintenance strategy, which is another area to look into. So we've talked a lot about platinum sensitivity and response to platinum as maybe enriching for folks that are going to respond to PARP inhibitors. And the DORA study, which is soon to open and accrue, is trying to answer that very question, really using standard of care platinum chemotherapy as a predictor, if you will, of who will then respond to a PARP inhibitor. So that trial looks at olaparib in patients who've responded to a platinum and add to it durvalumab with olaparib as a maintenance strategy, thinking this is a tolerable regimen to get away from the cytotoxic, but you've potentially enriched for wild type BRCA patients who may respond to a PARP inhibitor.
Because Mediola was BRCA mutation patients.
Correct.
And I guess we'll see whether the addition of the durvalumab might help the PFS. It's too soon to know there, but response rate wise, certainly safety was okay, right?
Yes,
right,
exactly.
That's something we don't have enough
unexpected
data yet on now to do, but hopefully it'll come. And like you said, even in the wild type could be really, really interesting.
Right.
But speaking of maintenance and ovarian cancer, it's tempting.
Yeah.
It's tempting.
Yeah.
You know, in the BRCA patients, I guess we'll be starting with probably olaparib anyway, you know, but what's the possibility? What tell us about the ovarian cancer? situation.
I think what Tiffany was just describing, the ovarian cancer treatment world has been ahead of us in that respect. They use the PARP inhibitors as maintenance in patients who have ovarian cancer, which is relapsed, platinum sensitive, and then several studies have shown that using a PARP inhibitor as maintenance improves the progression-free survival compared to a PARP inhibitor. So they've been doing that for a while. Interestingly, I think there are differences. That seems to work not only in patients with germline BRCA mutations in ovarian cancer, but also those with somatic mutations and all ovarian cancer patients. I think in the breast cancer world, we'll see whether somatic BRCA mutations respond the same to PARP inhibitors. We don't know that yet. There are some ongoing trials. And I think in those that don't have, hopefully the platinum sensitivity will be our biologic selector, because I think in general there's less BRCA-ness in wild-type breast cancer than there is in wild-type ovarian cancer. But it's an interesting approach.
I would like to see some randomized trials along those lines, because there will be some first-line BRCA patients in the metastatic setting who are pretty ill. And we're going to want to give combination chemotherapy, probably with a platinum agent, and then once they get a nice response,
take away the toxic platinum and give them a PARP inhibitor.
Switch over, there. So we're going to be doing that, but otherwise we're going to be probably starting with the olaparib. But then it's really the issue: can we use the platinum sensitivity, as the ovarian cancer docs have done, as a kind of a in vivo biologic readout, that you might be selecting for. That really makes a lot of sense, So really exciting days ahead, and hopefully, I'm holding out hope for the IO PARP inhibitor combinations, because biologically they really should work really, really well together with the PARP. The more DNA damage you can cause, the more you're going to get an antiviral sting response, to bring in the TIL, against, and the IO agent could really help that. So I'm holding out hope, that will be the case. So, really we're in the, the ascendancy of BRCA, really needing to know our patient's BRCA status, and we're kind of creeping up on a new subtype here. You think it might just be easier in the future that just everybody gets testing as soon as they're diagnosed, so we don't miss people? At least the HER2 negative, we don't have the HER2 positive, but it'd be a lot easier for me to try to just do it that way,
Well, you're preaching to the converted, I would have to say. I've always thought ER, PR, HER2, and BRCA in every breast cancer, but I think, what does the data say? I think if everybody were to use NCCN criteria, we'd find most of the germline BRCA mutation carriers. And if technology would help us do that, that would be great. But we're not there, and there's a lot of under-testing. And in fact, just this month, EPUB JCO has a paper in which they looked at patients, I think in Georgia and LA, they surveyed 5,000 breast cancer patients. They found 1,700 that fit NCCN criteria, and less than half of them had germline BRCA testing. And if you ask them why, that half that didn't get it, half of them said, I never even had a conversation. Forget about a genetic counselor with my doctor. So I think there's so much under-testing that anything we can do to identify every single patient with a germline BRCA mutation would be good.
Right. Even if we use this as an opportunity to remember to revisit family history, right? Because we have the pleasure of taking care of women for many, many years, and to recognize family history changes and updates over time. So use this as an opportunity to just check in and see, are we missing the chance to test someone who really deserves testing meeting NCCN guidelines?
Absolutely.
And it may be, as we get more data around PARP inhibitors and their efficacy across multiple germline mutations, it'll become more and more standard to just do the testing up front on everybody, because it won't just be BRCA. It won't be a larger subset. And also, of course, if we get the PARP inhibitors into the curative setting, and they show benefit there, then it's going to be even more compelling, to not miss those patients if it's going to have a positive outcome. What's going on, Tiffany, with the PARP inhibitors that you're aware of in the curative setting?
Yeah, so the Olympia study, building on Olympiad, is an early stage trial of a randomization to adjuvant olaparib versus observation or standard of care radiation, endocrine therapy if appropriate. And that's a global trial still accruing, and I think a really important one for women with early stage germline BRCA mutations. And in the setting of triple negative breast cancer, if those women did receive neoadjuvant therapy, they need to fail a path CR to be able to be a candidate for this trial. But I think that is one very compelling and important and worth keeping an eye on. In terms of other areas of interest, we've alluded to how important it is to figure out some of these other germline mutations and see if there may be a role for PARP inhibition there, as well as a potential role for somatic non-BRCA mutations.
And there's some work, I think, going on in the neoadjuvant setting too.
Yes,
What
I think
we're
at ASCO we're likely going to hear about some monotherapy talazoparib results in the neoadjuvant setting. I think Jen Litton at MD Anderson has completed enrollment to that trial. So I think we're going to hear about that. And I think other PARP inhibitors alone or with immune therapy are moving into the neoadjuvant setting. So I think there's going to be a lot more, and I think you're absolutely right. I think if there's a study and there look like there's some exciting results, the need to not miss a germline right from the beginning is going to become paramount.
Be huge, yeah. So that'll be interesting. That's going to be our first data just in a few months about preoperative talazoparib, single agent in the BRCA germline.
Yes,
Was it
germline
both
BRCA.
triple negative and ER positive?
I don't know the answer to that because I'm not sure.
Yeah,
we'll have to hear it
Wait
out.
and see. Wait and see.
Yes.
And I guess the other thing is, it is tempting to, think about, olaparib and hopefully soon to be talazoparib as well for the germline mutations that are similar to the to the BRCA1 and 2, like PALB2. I think of so similarly as BRCA2. For example, and they oftentimes will have triple negative breast cancer there. What do we know from other malignancies? Do we have any? Because we don't have any data in breast cancer yet, do we?
No, I will say that TBCRC, we've just opened a study looking at this question in breast cancer, looking at either germline or somatic other DNA repair mutations in other DNA repair genes, or just somatic BRCA mutations to see if olaparib will work. And prostate cancer is the cancer, the Mateo study in the New England Journal, that really showed some success with olaparib with either germline or somatic mutations in, for example, ATM. So this was a cohort in which they gave all of the metastatic prostate cancer patients with castrate-resistant prostate cancer olaparib, and they looked at who responded, and of the 16 patients who either had both copies of a gene mutated or both lost one of these DNA repair genes, 14 of the 16 responded to olaparib. So I think the key will be, again, just another way to get to these patients who don't have a germline BRCA mutation, who may have the same defect in this homologous recombination pathway. Another way may be just having a different mutation in this pathway, either in the tumor or germline.
Either way, and it was both somatic or germline.
Yes, when they saw, for example, ATM mutations in the tumor or BRCA2, only half of them were germline. Some of them were just somatic in the tumor. So that's promising.
That is promising, but they thought, probably you might need to have both copies of the gene gone. That still has to obviously be worked out, but with only one, you still may have enough gene function there that you're not going to get a good result. So we have to be careful, because now when we send our tissues, because we're looking for clinical trials for patients, we're looking, they had standard therapies, we're looking for mutations that might qualify for them, clinical trials, next-gen sequencing, and it comes up with a BRCA2 mutation somatically. We don't know now, whether that's really functional, right? It's not reporting out that what the is it both copies gone, or biallelic loss, right? So we would have to call up and find out. But your point, though, I think, Nadine, is you would say, just go ahead and do the germline.
I think in these studies post hoc, there'll be a lot of analysis about who responded and who didn't. I don't think there's a way in real time at this point. Obviously, if it's a germline mutation and the cancer is a signature one, breast or ovarian, there's a presumption, and actually many have shown that there's loss of heterozygosity for that loss of that wild type BRCA allele in the vast majority, 80 or higher, 90% of the cancers. So that, I think we have that assumption. I think what you're raising is if it's arose somatic only in the tumor, how do we know that both copies are really non-functional? We won't in real time, and we'll have to look at that.
So thank you guys so much. Really thorough, deep discussion. Just want to give you the opportunity to, leave us with one, or a couple of sort of take home messages, that you're gonna, that for all of us who are just, kind of getting used to these data and such.
Yeah. I feel like I'm stealing Tiffany's because she revealed it, so
mine may still be the same.
I would say that in metastatic breast cancer, don't forget to think about finding a germline mutation. It's really what Tiffany had said before, because now we have a new therapy. It's not just about preventive surgery and preventing new cancers in the future. This is about treating this cancer. So you can't forget, you have to think about how to test for it. I think I've started.
I would echo that. Yes. We'll leave more time for question and answers because I would say the same thing.
And that's going to help us, I think, as we focus more and more on the metastatic setting. It's going to raise the consciousness in general. Probably it'll spill over to the patients we're seeing in follow-up. So it'll be part of our algorithm that we go through, and more it is anyway. I think with these other germline mutations out there, we're thinking. I find myself redoing the family history, et cetera. But it'll probably raise the consciousness in general for the whole area and spill over into the curative setting. So just the beginning. So well, thank you guys so much, and I think this has been really an excellent discussion. We hope that you found the information to be very valuable for your clinical practice. Thank you for watching OncLive News Network.